Absolutely. Okay, well, why don't we get going? So thank you, everybody, for joining, and it is my pleasure to introduce our speaker this morning, Dr. Erika Hamilton, Director of Breast and Gynecological Malignancies at the Sarah Cannon Research Institute in Tennessee. Dr. Hamilton received her undergrad degree from Washington and Lee University in Virginia and an NCAA Postgraduate Scholarship. She completed her medical degree and residency at the University of North Carolina and fellowship training at Duke University. In 2013, she joined the Sarah Cannon Research Institute as investigator in drug development for women's cancer. And since 2015, she served as the director of the Breast and Gynecological Cancer Research Program. She is involved in patients with breast cancer in clinical trials spanning from phase 1 to 2 and 3. But she's also involved outside of clinics and clinical trials. She was named to the Women to Watch class of 2021 for Nashville Medical News. She serves on the board for local Susan G. Komen, was selected for ASCO's Leadership Development Class 21-22, is past chair of ASCO Scientific Committee for Metastatic Breast Cancer, and currently serves on ASCO's Cancer Research Committee, as well as the Scientific Committee co-chair of ESMO Breast Cancer Meeting, also involved as associate editor for Clinical Breast Cancer. So thank you again for joining us, and we'll look forward to your talk.
Thanks so much for having me.
Yeah, I just want to just a little bit of housekeeping. Please mute your phones during the talk, and please put questions in the chat, and we'll have question period after the talk. Thank you.
Sounds great. Well, I'm happy to join you virtually this morning. This is one of the advantages of things we've learned during the pandemic, is that we can all communicate via Zoom and chat, etc. So these are my disclosures, and this is a long list to say that we do a lot of clinical research, and I take no funds personally to me. All funds are to institution only. So we could argue whether that's really a conflict of interest or not. So this is kind of the agenda of what we're going to be covering today. We're going to talk about some of the key clinical trials for HER2 positive agents, what I see the current treatment algorithm as, talk about some of the adverse events, how I manage these in practice, and then also hit upon some sequencing, which I think is kind of where we're headed and what might mix the field up a little bit, and new agents that are on their way. So I tried to make this a little bit Canadian specific. I think you guys are probably all familiar with these statistics. Same 15% of patients that have HER2 positive disease. About 7% of patients have metastatic disease at diagnosis. And unfortunately, despite the fact that we're really doing much better in breast cancer than some of our other tumor types, 5-year overall survival rate is still only about 40% if patients have metastases. So how does HER2 stack up in compared to hormone receptor positive disease or triple negative disease? It used to be that HER2 positive and triple negative were kind of the dreaded ones. And HER2 really is doing much better than we are with triple negative now, but still 5-year survival is really kind of around 40% for patients that have HER2 positive disease. So I'm going to start this talk by kind of saying where we were about 4 years ago, because this really has changed a lot in the past couple of years. So in 2018, we had TDM1 is our antibody drug conjugate. We had 2 antibodies, trastuzumab and pertuzumab, and then we also had 2 tyrosine kinase inhibitors, both lapatinib and neratinib. And so our treatment algorithm was really taxane in combination with trastuzumab and pertuzumab first line. We used TDM1 second line, and then third line was a little bit up for debate, depending on patient characteristics, brain mets, desire for oral or IV. We really used chemotherapy with trastuzumab again and kind of recycled trastuzumab, or we used capecitabine in combination with lapatinib. So let's walk through a little bit of the data here. So this is the Cleopatra trial. This was how we ended up with pertuzumab in the first line setting. And so you can really see in this blue line, this is with the addition of pertuzumab to docetaxel and trastuzumab, and we improved progression-free survival by about 6 months. So essentially from 1 year to 1.5 years, but we got a 16-month improvement in overall survival. So really quite impressive there. And in fact, taxane with trastuzumab and pertuzumab has been our first line regimen now for quite some time. So I'm going to follow this case kind of through a little bit. This is Nicole. She's 55-year-old, so a younger postmenopausal woman who had some hip pain and actually presented to her primary care doctor, and she hadn't had her mammogram due to COVID, which I think we're all seeing quite a few patients that are in this circumstance. On exam, she was found to have a breast mass that appeared to be about 3 centimeters, also had some right axillary adenopathy. She had a biopsy that was ERPR negative and HER2 3+ by IHC. And on imaging studies, she unfortunately had bone mets that were prominent to her sternum, as well as the left hip where she had pain, and also some supraclavicular adenopathy. So in terms of gold standard for her, I think this is pretty easy. We're thinking about Cleopatra, so taxane, trastuzumab, pertuzumab, and unfortunately, this lady has de novo presentation of HER2 positive disease. So she's tolerating docetaxel pretty well. She has a little bit of neuropathy, a little bit of nausea, a little bit of fatigue, and obviously has alopecia from the taxane. And in cycle 6, she's just becoming more fatigued. She has another echo. Echo looks good, not a cardiac source of her fatigue, but she's not able to exercise anymore. She's not able to work full time. And so we discussed with her dropping out the taxane at cycle 7 and continuing HP alone and add an aromatase inhibitor. And so she actually goes on to receive about 23 cycles of aromatase inhibitor in combination with herceptin.
SMW, can you please mute yourself?
Yeah, I think there's a little bit of background noise. So let's move to Amelia. Amelia was our trial where we looked at TDM1 for second line. And TDM1 will give you the hint, as you guys all know, really was the previous standard of care in second line. And so progression-free survival was improved by 3.5 months with TDM1 over capecitabine lapatinib, and overall survival was improved by almost 6 months. So that brings us to trastuzumab deruxtecan and the current state of affairs. So I think we're all familiar with antibody drug conjugates. To be quite honest, we have more antibody drug conjugates in the breast realm as some of the other tumor types, although they're certainly getting approvals as well. Really, antibody drug conjugates bind to the target receptor antigen. They're internalized into the cell. The cytotoxic drug is released. And what's unique about trastuzumab deruxtecan, at least, is that then this can actually transfuse back across the membrane to extracellular space and affect some neighboring cells, therefore our bystander effect. So what's unique about trastuzumab deruxtecan? It has a topoisomerase 1 inhibitor payload. It's an exatecan derivative. It has a drug to antibody ratio of about 8. And definitely has prominent bystander anti-tumor effect. And so when we compare this to TDM1, certainly we're seeing some very different activity in terms of efficacy, as well as populations who benefit with TDM1. And so if we look at TDM1, it has a microtubule payload. Its DAR is about 3.5 to 1. And it doesn't have the tumor selective cleavable linker or a lot of bystander activity. So I think with these structural differences, we can see why we're seeing some different properties with trastuzumab deruxtecan. So DESTINY-Breast01 was our first trial with trastuzumab deruxtecan. This was a heavily pretreated patient population. The median number of priors was actually around 6. And the overall response rate in the top left that you can see really was quite remarkable. About 61% of patients having an objective response, and really more than 95% of patients having at least some tumor shrinkage and their first scan looking good. And I think we can all agree that that's what our patients care about, is kind of getting to that first scan. It looks good. They don't have progression out of the gate. The duration of response was actually quite long too, almost 15 months. But the one thing that worried us a little bit was on the right side of the slide with ILD. We saw about 13% rate of ILD. The majority are grade 1, grade 2. But we saw 2.2% of patients that actually had fatal grade 5 pneumonitis ILD. And so based on this study in 2019, the FDA approved trastuzumab deruxtecan right before Christmas here in the United States for patients that had HER2 positive disease that had seen at least 2 prior regimens. Now, there was a lot of talk about the CNS MET subgroup. This was a little bit different than the trial that we'll talk about, HER2CLIMB. So brain mets were allowed, but the classic brain mets that we see, so treated and stable. And what did we see here for those patients that did have brain mets? Caution you that these are small numbers. There was only about 24 patients on trial, but we saw that the progression-free survival was not shorter at all. In fact, numerically, it was a little bit longer. And so kind of made us feel pretty good that patients were getting benefit, but it still left the question about, well, what about patients that have active brain mets? Is this really getting into the brain well? So our next trial was DESTINY-Breast03, and this was the trial looking at moving trastuzumab deruxtecan up into the second line. So now we were comparing it head-to-head with TDM1 in a 1-to-1 fashion. And as we say in the Nashville, Tennessee, this is the curve that you can drive a truck through. Hazard ratio of 0.28, which I think many of us haven't seen a hazard ratio that good in breast cancer in quite a few years. Response rate certainly higher with trastuzumab deruxtecan as well, about 80% compared to 35%. And in the blinded independent central review, the progression-free survival with trastuzumab deruxtecan wasn't quite reached. So when we do the dreaded cross-trial comparisons and put everything on a slide, you can see that trastuzumab deruxtecan was really giving us much more benefit than TDM1, and in fact, really all of our agents in the HER2 positive space. And this was based on local review, not the blinded independent central review. So let's go back to Nicole. So recall that she'd been on aromatase inhibitor with trastuzumab and pertuzumab now really for over 2 years. And on scans, she now has 3 new liver lesions. The largest is about 2 centimeters. She also has growth of some of her lymph nodes, mediastinal, as well as other locations. She has normal liver function, no issues with AST, ALT, or bilirubin. And so based on the current guideline recommendations, Nicole goes on trastuzumab deruxtecan in the second line space. And so I've tried to pull these from the Canadian treatment recommendations. You can see on the top of the screen, we had taxane, trastuzumab, pertuzumab. And now in the middle that's highlighted, really you have trastuzumab deruxtecan as well as capecitabine, trastuzumab tucatinib. And I think most people are probably using trastuzumab deruxtecan for the majority of patients, but some patients that really have prominent symptoms and active brain metastases, that may be a circumstance that I'm thinking about using the tucatinib regimen instead, just because of the strength of the data and the overall survival benefit there. So we did update some safety from DESTINY-Breast03. If you look kind of across the arms, really grade 3 treatment emergent adverse events were quite similar between trastuzumab deruxtecan and TDM1, about 50% either way. There were more patients that discontinued trastuzumab deruxtecan compared to TDM1, about 7% versus 14%. And really what drove this was about the 8% of patients that did need to discontinue trastuzumab deruxtecan due to ILD pneumonitis. And we see the treatment duration is really disproportionate between these arms. TDM1 at about 7 months and trastuzumab deruxtecan a little bit over 16 months. When we look at exposure adjusted incidence rates, or essentially comparing for the amount of time that somebody was on treatment, really the side effects equalize and really look more advantageous for trastuzumab deruxtecan. So the exposure adjusted incidence rates for grade 3 treatment emergent adverse events was 0.42 with TDXD, 0.7 with TDM1. And when we talk about serious adverse events, again, it's lower with trastuzumab deruxtecan, 0.17 and 0.27 for TDM1. So what are the side effects that we most commonly see? It's really GI, it's nausea. And I think that that's pretty much the only place that people really get into trouble is if they don't give antiemetic pre-meds appropriately for trastuzumab deruxtecan. And that really can be a prominent symptom for a lot of patients, with essentially 3/4 of our patients having nausea. We certainly do see fatigue, just like we see with any cancer therapy, and we can see neutropenia as well. I think the other thing to point out and really to discuss with patients is alopecia. Some of our other antibody drug conjugates, TDM1, sacituzumab, et cetera, that's less prominent, and patients really can have substantial hair loss with trastuzumab deruxtecan. So important to let people know that ahead of time so they're not mad at you when that happens. So what did we see in terms of ILD pneumonitis? I thought that this was really quite reassuring compared to Destiny Breast 01. Essentially, when we recognized that we had fatal pneumonitis ILD events with trastuzumab deruxtecan, pretty stringent monitoring parameters, hold parameters, and discontinuation parameters were put in these studies. And so for grade 2 or greater ILD pneumonitis, it was a discontinuation and not a re-challenge. And that's really different than the way we treat ILD pneumonitis for immunotherapy, et cetera, where we don't really do much until grade 3. And even for grade 1 pneumonitis ILD with trastuzumab deruxtecan, we hold drug, and if it improves and resolves within 4 weeks, we can re-challenge. So with these parameters, we eliminated grade 4 and grade 5 ILD. And in fact, grade 3 ILD was less than 1%. And so I think this really gave us a lot of confidence that we could safely give this drug and that it was appropriate to potentially move it up into the earlier line settings. So based on this, in May of this year, trastuzumab deruxtecan was approved for essentially second line HER2 positive disease, or those that relapse within 6 months of anti-HER2 directed treatment. So let's go back to Nicole. Nicole was put on trastuzumab deruxtecan in the second line setting. She had a little bit of issues with vomiting. It was grade 2 in the first cycle. More antiemetics were added. She kind of settled into the regimen and figured out how to manage this at home, and is under much better control and is grade 1 now, still with her fatigue and alopecia. And so I bring this up just around recommendations for nausea and vomiting with trastuzumab deruxtecan. Here in my institution, we standardly start a 3-drug antiemetic regimen for everyone, and then kind of peel back from there. And for us, that's ondansetron, dexamethasone, and an NK1. So you can see kind of that top part of the bullet here. And then certainly make sure that patients have antiemetics at home. I typically make sure that my patients have ondansetron as well as prochlorperazine, and they can kind of rotate that. Certainly for patients that don't have a lot of nausea, you can scale back from there, but I found that this tends to be pretty effective for most patients. So I found this slide pretty interesting just in terms of nausea and vomiting. And I think it's important for us to recognize this, because I think that that's the one spot that sometimes we make mistakes, is thinking, well, the antibody drug conjugates have less side effects, and so I don't need to really worry about all of these antiemetics. And so you can see TDM1 in the top left in blue, and really showing that, you know, nausea is not that prominent of a side effect. And then over on the right, you see trastuzumab deruxtecan, where when we graph out side effects, really nausea and vomiting is very prominent. And in fact, even with sacituzumab, much more prominent than TDM1. So kind of gets back to this, not all antibody drug conjugates are created equal, and really kind of being aware of this, and then helping our patients with prophylactic antiemetics, I think goes a long way in their tolerability and ultimately their satisfaction on this drug. So I think we've really covered this. This really just talks about the pre-meds again, and then also kind of a way to escalate if they're not doing well, alternative drugs to use like olanzapine or metoclopramide, et cetera. I really find with my 3 initial drugs, I have not had very many patients that have needed anything in addition to having some ondansetron and prochlorperazine at home. So what about interstitial lung disease? So I think this is important, particularly to educate, our community practitioners who I don't know how they do it, but see all tumor types and keep all this sorted in their brain across multiple tumor types and drugs. So really, ILD grading, grade 1 is completely asymptomatic. So how do you find that? Well, it's based on surveillance scans. And grade 2 is any symptoms. Grade 3 is really when we're talking about patients that need oxygen or having severe symptoms. And so I'm really pretty aggressive on making sure that my patients are aware of this. I think as trastuzumab deruxtecan kind of goes out everywhere, it's my worry that somebody that's an older woman is going to go to their primary care doctor or is going to go to an urgent care clinic and be diagnosed with bronchitis or something and given antibiotics and steroids. And really, there's the potential to miss that they're on a drug that potentially may cause ILD. And so I make sure that my patients are aware of that if they have any shortness of breath, any pulmonary symptoms that I need to know, and also kind of educate them that if they're seeing other providers, to let them know that they're on a drug that may cause ILD pneumonitis, because really it appears that early intervention is the key here to make this not lead to fatal ILD pneumonitis. So again, on the far right part of the screen, dose interruption, discontinuation for even those that have grade 1 asymptomatic. I typically just give them a really short course of steroids and then repeat my scan, make sure it's gone and restart. And I've been successful doing that. The problem is if they get to the point that they're symptomatic for grade 2 or greater, it's recommended that you permanently discontinue drug. So again, this is just outlining steroid recommendations, et cetera, as well as some dose modifications that we have for trastuzumab deruxtecan. So what about our guidelines here? So on the left, you've got the ESMO guidelines. On the right, you have NCCN guidelines, and really are quite consistent that we're still thinking about taxane, trastuzumab, and pertuzumab first line. And then we have the choice between trastuzumab deruxtecan second line. I think we're really not using a lot of TDM1 there. And then we also have approval of CAPE tras tucatinib here. So I think food for thought is, should or will we start ordering brain imaging on all of our patients at time of treatment changes for HER2 positive disease? And I think, we've been talking a lot about this, at least here in the United States. In my practice, it's not yet quite standard to do this uniformly. I think we all have a very low threshold to order brain imaging. If somebody has nausea out of the realm of what we would expect, if they're having continuous headaches, any imbalance or neurologic symptoms, et cetera. But, especially where we have drugs that actually work in the CNS now, it becomes a question of, should we be ordering this at the time of treatment changes to help us make this decision? So certainly something we can talk about at the end of the talk. So let's move to tucatinib. I'm sure some of you were hearing that we have had tucatinib, although it was ONT-380 back in the day, since 2013 in my clinic in the phase 1. So we've kind of seen this through the entire development. What's unique about tucatinib is that it's a HER2-specific tyrosine kinase inhibitor, compared to lapatinib and neratinib that hits not only HER2, but also HER1 or EGFR. That's where we get a lot of our side effects of rash and diarrhea. Tucatinib is really highly HER2 specific, and so tends to be a little bit better tolerated. And then we can also dose it really where we need to for activity without getting into trouble with side effects. So this was the HER2CLIMB trial. It was the phase 3 registrational trial for tucatinib. And in this red box on the left, you'll see I've highlighted that this really was a unique trial, and it was the first one of its kind. Not only did it allow patients that had HER2 positive brain mets that were treated and stable, but it also allowed patients that had untreated brain mets or patients that had treated brain mets that subsequently were progressive. And so this was a really high risk population. We'd never really seen a trial that included those type of patients, particularly in a phase 3. So patients were randomized in a 2-to-1 fashion to get CAPE trastuzumab or CAPE trastuzumab and tucatinib. And in fact, with those brain met criteria, about 48% of the patients that enrolled on trial actually did have brain mets in one of those 3 categories. And the trial hit all of its primary and secondary endpoints: improved progression-free survival, improved overall survival, improved progression-free survival in patients with brain metastases. And when we look at brain metastases, on the left side of the screen, you'll see that 48% of the patients on trial, all brain mets, and our hazard ratio was 0.32. So an improvement of progression-free survival from 4.2 months up to 9.9 months. And if we look on the right side of the screen, this was specifically those patients that had really high risk brain disease. So those that were untreated in the brain or had treated either surgery or radiation, but were subsequently progressive. And here you can see quite similar hazard ratio of 0.36 and progression-free survival of 4.1 or 9.5 months. The other thing I'll draw your attention to in this slide is essentially the progression-free survival. If you weren't on tucatinib at 12 months, nobody was still on therapy, where we have 30 to 40% of patients still on therapy at a year with even these high-risk active brain metastases for patients that receive tucatinib. What about overall survival? So again, on the left of all brain metastases or on the right with active brain metastases, highly statistically significant hazard ratio of 0.58 or 0.49, and really improving overall survival in our patients with brain metastases from 1 year to 1.5 years. So what side effects do we see? The burgundy bars are capetrazolone. And so I point that out because the majority of side effects we see with this regimen really come from capecitabine. Certainly our hand, foot, some of our GI toxicity, fatigue, etc. And when we look at the blue bars, fatigue really doesn't look any higher with tucatinib. Nausea is a little bit higher. Hand, foot, again, that's all just capecitabine exposure. Tucatinib does not cause hand, foot syndrome. And diarrhea is a little bit higher. They actually did an analysis based on duration on treatment, and a lot of that increased diarrhea was actually due to the longer duration of patients that were receiving tucatinib. I'll call your attention all the way to the right of the slide, AST increase and ALT increase. That is a side effect that can come from tucatinib itself. So that's the one side effect here where I think about reducing both my cape and my tucatinib instead of only reducing my cape first. So all the other side effects, vomiting, fatigue, hand, foot, diarrhea, I typically reduce my capecitabine and I leave my tucatinib alone. So what are the formal management of diarrhea? I think we are all familiar with this across multiple TKIs and other drugs. We really recommend loperamide initially. If loperamide persists, we can think about Lamodal, even octreotide, etc. I've really never had anybody that Lamodal and Imodium are not enough for. So what are the dose modifications for some other adverse events? And maybe I call your attention to the middle part of this slide for the hepatotoxicity. Certainly very scripted interventions for elevated bilirubin, ALT, AST, etc. for grade 3, hold until this resumes to grade 1, and then dose reduce, whereas at grade 2 we can resume at the same dose level. And then for any grade 4 adverse events, it's recommended to discontinue. So let's go back to Nicole. So Nicole actually reports more shortness of breath when climbing the stairs in her house. She obviously got great benefit from trastuzumab deruxtecan. She was on for 38 cycles. And so pulmonary imaging was ordered, and indeed it showed pneumonitis ILD. And so with her symptoms, this would be grade 2 ILD that's symptomatic. Her trastuzumab deruxtecan was discontinued. We re-imaged her systemically. Her CT and her bone scan actually revealed stable disease, but her brain MRI showed 3 small lesions in the right frontal lobe suggestive of new brain metastases. She ends up having SRS for these 3 small lesions and does perfectly fine with this. And she goes on to receive capecitabine, trastuzumab, and tucatinib at this point. And so my dreaded cross-trial comparison slide. Again, just showing our benefit with tucatinib over CAPE trastuzumab for progression-free survival. And then also remember that overall survival benefit for patients, particularly that had brain metastases as well. And so this is very in line with Canadian treatment recommendations for subsequent lines of therapy. Certainly we have TDM1, we still have capecitabine, tucatinib, trastuzumab. We have single agent chemos in combination with trastuzumab, and then still have some lapatinib combinations as well, although I find that we're using those a little bit less these days. So let's talk a little bit about CNS disease. We know for our HER2 positive patients, up to 50% of patients will ultimately have HER2 positive brain metastases at some point in their metastatic treatment journey. This really just compares some of the activity. Historically, we haven't thought about the ADCs as being a class of drugs that really crosses the blood-brain barrier due to size. But what we're learning is with brain mets that certainly the blood-brain barrier is disrupted, particularly so if patients have had surgery or radiation. And we're really seeing pretty good responses with some of these antibody drug conjugates. We saw it with TDM1. We're certainly seeing it with trastuzumab deruxtecan now. And then we do have the 3 tyrosine kinase inhibitors at the top. And there's some data in there for you to look at as well. So in HER2CLIMB, the overall survival in patients with active or stable brain metastases, again, this is just a different representation of what I showed you on the other slide. But essentially, you can see at the two-year point, overall survival, 21% if you only received CAPE Traz, and CAPE Traz tucatinib being about 50%. Obviously, these patients went on to other lines of therapy if they were on trastuzumab, CAPE, et cetera. And if we look at treated stable brain metastases, overall survival still being 5 months longer in the tucatinib arm. So it's not a drug only for patients that have active brain metastases. It certainly is active in those that have treated and stable, and it's active in patients that don't have brain metastases at all. So what did we see in DESTINY-Breast03 for patients that have brain metastases? Again, this is different. These patients didn't have active brain metastases. They hadn't progressed after local treatment, et cetera. But we saw that the patients with brain metastases were still deriving fantastic benefit from trastuzumab deruxtecan. So a hazard ratio of 0.25. And again, compared that to the patients that didn't have brain metastases, really the benefit is just as good, if not a little bit numerically greater. Now, this is where things become a little bit interesting. So what about the intracranial response? So you see with trastuzumab deruxtecan, despite the fact that this is a big antibody drug conjugate, really impressive intracranial responses for patients that had brain mets. Now, certainly these patients were all treated and stable, so they did have a disrupted blood-brain barrier, but really you can see about a quarter of patients having complete responses in the brain and another 36% having partial responses. So what about NALA? I figure we had to cover this just to be complete, but we won't spend too much time here. NALA was our trial looking at capecitabine with neratinib, which is a pan-HER2 TKI, so hits HER1, HER2, et cetera, plus CAPE versus CAPE with lapatinib. There was about almost 2.2 month improvement of progression-free survival favoring neratinib. And there was a benefit of almost 2 months in overall survival favoring capecitabine neratinib. Now, remember that this was compared to CAPE lapatinib. So we do see incremental benefit, but it also comes with a little bit more cost of a little bit more difficult to treat diarrhea. So here you can see that for capecitabine neratinib, really universally, most patients are having diarrhea, whereas about 2/3 of patients are having diarrhea on capecitabine lapatinib. But we see about a doubling of severe grade 3, grade 4 diarrhea, up to about a quarter of patients on capecitabine neratinib. Now, we've gotten a little bit smarter in how to control this. So the control study really looked at a dose escalation of neratinib. So for 1 week, really starting at 3 tablets a day. The second week, you take 4 tablets. And then week 3, you go up to the full dose of 6 tablets. And this was actually very effective. It really kind of makes the diarrhea more mild. Patients learn how to manage it. The body also gets a little bit used to taking the neratinib. Always when we do this, I think our worry is, well, are we going to get to full dose? And in fact, 93% of patients did escalate to the full dose of neratinib at week 3. So really showing that this can be an effective strategy instead of piling on so many other medications for our patients who really, start to get a little bit distressed by the pill burden. So if we look at extenet versus control, so you can see, if we use loperamide or loperamide plus budesonide or clestipol, which actually came from the GI literature world with loperamide, all these preventative strategies did work quite well to prevent grade 3 diarrhea, but I typically use the escalating doses and also use some loperamide at home, and I find this works quite well. So where do we stand in terms of algorithm? So now here in the United States for the FDA, things have changed a lot since 2018. We have adjuvant TDM1 in 2019. We had the approval of trastuzumab deruxtecan, and then in 2022, it was bumped up to second line. In 2020, we got the approval for tucatinib and neratinib in the metastatic setting, and also margetuximab. So really, things have changed dramatically in the past 4 years in HER2-positive metastatic disease. And so I show you this same slide that we talked about at the beginning. So our approved targeted therapies now, we still have TDM1, but we have trastuzumab deruxtecan added. We have tucatinib, our HER2-specific tyrosine kinase inhibitor. And then we also have the HER2-targeted antibodies, trastuzumab, pertuzumab, and margetuximab. So this is how I see the current treatment algorithm. Taxane, trastuzumab, pertuzumab first. For most patients, trastuzumab deruxtecan second. I think there's certain situations that you could think about TDM1, patients that have very low burden of disease, maybe bone only, elderly, etc. We also have CAPE trastuzumab, which I'm typically using in more of a third line space. We certainly have the option to come back to TDM1 there. I think if we get into potential sequencing questions, at least for me, the mechanism of resistance to trastuzumab deruxtecan is a question for me. Is it the payload? Is it downregulation of HER2 on the cell surface? Conceivably, if you do have downregulation on the cell surface, then maybe coming in with another antibody drug conjugate that's really counting on that is not the wisest. So I'm typically using CAPE trastuzumab after TDXD and then kind of circling back around to TDM1 after. We don't have a lot of data for this, and certainly don't have a data of what progression-free survival we're really getting with TDM1 now after TDXD, but hopefully we will. And then we certainly have clinical trials, always appropriate. We have chemo with margetuximab. We also have chemo with trastuzumab again. We've got CAPE in combination with lapatinib or neratinib. And so, in fact, there was a paper published just this year talking about sequencing from the Canadian perspective in HER2-positive disease. Again, also encouraging any clinical trials if you have these. And so here is the whole build out of the summary that we've been going through. And so I think really, whether we're in Canada or whether we're in the United States, this is really quite consistent. I think some of our bigger questions are, will trastuzumab deruxtecan ultimately be used first line? Where does that leave pertuzumab? How will we do sequencing then? And what about our patients that we may eventually get a trastuzumab deruxtecan approval in the neoadjuvant or the adjuvant setting? Those trials are ongoing. And how will that play into our treatment sequencing for patients that end up with metastatic disease? So what's next? What's coming? So these are ongoing trials with either trastuzumab deruxtecan or tucatinib. And as you can see, there are multiple. We have DESTINY-Breast07 that are looking at combinations with trastuzumab deruxtecan in the first line setting. So combinations with endocrine therapy, combinations with AKT, combinations with chemo like capecitabine or taxane. We have DESTINY-Breast09 that's looking at TDXD in the first line setting head to head with THP, and also having that third arm with TDXD plus pertuzumab in there. So a very clean first line trial. And then we also have DESTINY-Breast12 that's looking more at patients with brain mets. We have HER2CLIMB-04. I'm very excited about this trial, combining trastuzumab deruxtecan with tucatinib. So our two popular agents at the party, putting them together. We also have HER2CLIMB-05, which I think is a very interesting strategy, looking at patients in the first line when they get their THP, when the taxane drops out, and they're going on to HP maintenance, thinking about potentially adding tucatinib there. I'm really hopeful that maybe this will cut down on future brain metastases as we put an active brain agent earlier in lines of therapy before those brain mets develop. I always think that that's the best treatment strategy, is a bit of prevention. So we'll see. And then together is looking at pembrolizumab combos, et cetera. So a lot is coming. So thoughts I'm going to leave you with, and then I think I've left plenty of time for us to have a discussion and go over some of your questions. But trastuzumab deruxtecan continues to move earlier in the treatment. I think we all think that it will win in the first line setting. I think we all think that we'll get an approval in early stage disease as well. As we refine the use of these new agents, our sequencing may shift. If we have a benefit of adding tucatinib with trastuzumab and pertuzumab, we may end up with tucatinib there and go away from the capecitabine backbone. If we end up using trastuzumab deruxtecan earlier, that's going to put a little bit of a wrench in our sequencing as well. And brain mets continue to be a large problem for our patients with HER2 positive disease. Really 50% of our patients with metastatic disease will have brain mets, and leads to not only morbidity, but also mortality. And there certainly are novel agents in all of these classes: antibodies, bispecifics, antibody drug conjugates, immune-based strategies where maybe a molecule has something like trastuzumab on one side and a CD3 receptor or PD-L1 on the other. So really trying to bring immunotherapy to HER2 positive disease as well. So thank you so much for listening. Let's see if I can get back to the main screen. Okay, perfect.
Okay, thank you. Thank you so much for a great talk and a very nice review. Maybe I'll just start with a question about pulmonary toxicity in particular. I know that it's the median time to onset is about 6 months, and I'm just curious if there's any kind of baseline testing that you would do, like, I don't know, if you incorporate PFTs, or, and then also what's the frequency of your scan, at least in the beginning?
Yeah, those are great questions. So, you know, I think we were all hoping that there was some other way to kind of predict who was at risk for ILD pneumonitis, or a better way than just kind of seeing it on scans or waiting for patients to have symptoms. We really don't have any data that PFTs are predictive of this. You know, it's really interesting. You know, so I typically really rely on my scans. It's tough with an agent now that has such a long duration of benefit, because that's typically the place that we would start spacing out our scans for our patients and not making them do scans every 6 or 9 weeks. But I keep my scans for trastuzumab deruxtecan every 9 weeks for that reason. Just because I know if patients end up symptomatic, they have to discontinue, where if we can catch a little blip on a CT scan, give a little steroids and get rid of it, they can stay on therapy. So I do every 9 weeks. All the clinical trials were every 6 weeks, but I keep my, you're not going to get, you know, insurance approval for that. So I tend to keep my scans at 9 weeks for TDXD.
Okay, thank you. I see Andrew has, I guess, 2 questions.
Yeah, sorry, they're in the chat, but I can go ahead. First of all, thank you for an excellent summary and talk. First question is just regarding the emetogenicity of TDX. So in Ontario, it's classified as a single day moderately emetogenic regimen, which means that we can't use an NK1 unless it's the second cycle. And I guess my question is there any thoughts of reclassifying it as a highly emetogenic regimen? And the second question, which is totally unrelated, is you mentioned a lot about brain metastases. I wonder if your approach is similar for the leptomeningeal disease patients. I know those are even further excluded, but I've had, you know, some problems with that aspect of disease. Thank you.
Yeah, so, TDXD is classified as moderately emetogenic here as well. It looks like from your algorithm that you use olanzapine as your third drug. I mean, I would think that that would be fine. I tend to use olanzapine if they're not controlled. So I think we just kind of do a flip-flop. We're both using dexamethasone and ondansetron. You're using olanzapine up front as your third drug and then adding NK1. I'm using NK1 up front and then adding olanzapine. So that probably has to do with kind of formulary and, cost of drugs in different places. But I would think that those 3-drug antiemetic regimen to start is probably sufficient for patients. But, that would be something good to keep track of what percentage of patients are needing that NK1 added. And certainly, if it's a lot of patients, then maybe that does need to be, looked at again.
And the flip side is how many do you reduce?
I don't tend to reduce a lot. And it's mainly because it's not that their nausea isn't well controlled, it's that it is controlled, but it's not absent. And so I'm just hesitant to drop a whole lot down. I certainly have a few that are just like, yeah, I'm completely fine. I have, a little bit of nausea for 2 days. I've never thrown up. I'm great for the remaining 3 weeks. And so we have reduced some of the meds on those patients. In terms of leptomeningeal disease, I think that's like one of the biggest problems of our time right now. So the problem is there's very little studies there. The TBCRC, I know Nancy Lynn has done some work here. They actually have tucatinib in some specific trials for leptomeningeal disease that I anticipate that we'll hear results for soon. I think in the absence of clinical trial data, you've got to figure out how to treat these patients, that are sitting in front of you. And so I would feel quite comfortable using trastuzumab deruxtecan or Kate-Traz tucatinib for these patients. Unfortunately for leptomeningeal disease, when you get into IT chemo that we try and stuff, it's just really miserably tolerated. And these patients still have such short lives and poor outcomes, you really start to wonder whether it's worth it. So I have used tucatinib for a patient with leptomeningeal disease, got benefit for a little bit over 6 months, which wasn't bad. And I certainly wouldn't have anticipated her to do any better than on IT chemo.
Thank you. There's another question in the chat from one of our colleagues, April. She's wondering, when you give weekly paclitaxel upfront with HP in first line, if you give it day 1, 8, 15 on a 21-day cycle, or only day 1 and 8?
Yeah, I tend to use the Q3 week taxane with HP in the first line, just because patients don't want to come in weekly. There have been some situations where, I really don't want to drop somebody's counts. Somebody has, a fungating breast mass on the chest wall with a super infection that I would be, likely to use weekly for. And in those cases, I've used it days 1, 8, and 15. But my standard really is that every 3 week. Just so patients are only having to come in once every 3 weeks. A lot of our patients drive from pretty far away, and so it's a little bit of a burden for them to have to come in weekly, not to mention chair time.
So anticipate that would be docetaxel rather than paclitaxel than the Q3 weekly one?
Yep.
Okay. So I don't see anybody else here raising their hand, but I am just curious with a brain metastases and the monitoring. Of course, we are not yet doing routine brain imaging outside of symptoms. Anticipate that will probably change over time. I'm just curious, if you were to start doing routine brain imaging, would you start that right off the bat with first line treatment, and then that gets at a different situation where we do sometimes find patients with isolated progression in the brain, and we tend to treat that with a local treatment of SRT, and still continue the same regimen. So then the question becomes, well, do you still have to use radiation, but would you be then switching early and maybe losing some of the first line treatment effectiveness? So not sure where is that going now?
Yeah, I think there's two prong parts to that question. So the first one is, well, when would we image? And I don't know that I have a great answer for that, right? I mean, I think at a minimum, it needs to be at treatment changes, maybe where that information would, you know, affect what you might select for the patient. But you're right. I mean, sometimes patients, you know, like in the case of Nicole, you know, have stable systemic disease. They only have brain disease. And so should we be doing it at every one of our restaging scans? Should we be doing it every 3 months, every 6 months? I don't know. And, you know, unfortunately, there's definitely a cost implication side of that, but there's also an implication of having brain mets grow to the point that we finally find them. And then now it's 3 centimeters and we would have been able to much easily treat it when it was a lot smaller, right? So I don't have the perfect answer to that. In terms of the second part of your question, typically, you know, if somebody was on taxane, trastuzumab, pertuzumab, and had isolated brain mets in the absence of systemic progression, I typically treat those locally with SRS radiation and continue on the THP. You know, for isolated brain disease, particularly in a drug that we don't anticipate has a lot of activity for brain disease, I'm not using that to switch therapies at that point. I mean, certainly, you know, if it's a large burden of disease, you know, resistant to treatment, et cetera, certainly can consider, but I'm typically treating the CNS and staying on that line of therapy.
And where do you see the use of radiation? Are we going to start just treating systemically the brain mets?
Yeah, that's a great question. You know, as part of the HER2CLIMB trial, we actually had the opportunity, you know, to put patients on that hadn't had any local treatment. I'm always a little bit embarrassed to admit this because people probably think I'm crazy. But I had one patient that had a 4 centimeter brain lesion. It was only allowed on trial for 2 centimeters or left without discussion with medical monitor, but she would not do radiation. 100% opposed, said like, I'll do nothing, but I'm not doing brain radiation. And so I put her on trial and it dramatically shrunk to less than 1 centimeter. Now, am I going to do that in my standard practice? Take people that have 4 centimeter brain mets and not treat them locally? No. But I mean, I think it certainly does, you know, raise the question of these little asymptomatic 8 millimeter ditzels that we find. Do we really need to use our radiation card there? Or could we put, you know, patients on a tucatinib and save radiation for later? Because at least in my practice, I think we're getting better at keeping these patients alive for longer and longer. And I run into patients that then I want to do radiation and I can't because they've already been radiated too much there or it's too close. And so I think we do have to be thoughtful about, you know, sequencing and kind of when is the right time to radiate. I think that's going to be a hard trial to design, right? So we're kind of left at our best discretion and collaboration with our radiation oncologists.
Yeah, absolutely. We've seen shifts in other tumor sites too, like in melanoma now. We just do, you know, we have very active drugs in the brain, so we reserve radiation for when those fail. So I can't see any other questions in the chat or any raised hands. So with that, I want to thank you again for a great presentation, and we all learned a lot today. It's getting very busy again in the HER2 space, but that is a good thing for patients down the road. So thank you again, and thank you everybody. Please don't forget to complete the evaluation after the session.
Thank
Have
you.
a great day.
Have a fantastic day. Thanks for inviting me.
You too. Bye.